Thank you for that kind introduction. So I don't have any relevant disclosures. I'll get right into this. My topic's on CT-based FFR. We've talked a lot this morning about the benefits of coronary CTA. I think one element of coronary CTA that really sets it apart from other imaging modalities is the fact that it can evaluate coronary atherosclerosis throughout really the entire continuum of disease, including at a very early subclinical level, and that's been great. We've leveraged the benefit of coronary CTA for its negative predictive value, so safely excluding coronary disease in patients low to intermediate risk. Those who have a negative exam or a near negative exam, we can safely, confidently assume that they do not have high risk for downstream events and that they do not have obstructive coronary disease. Over the course of the last several years, we've seen an expanded use case for coronary CTA. So now we're able to leverage AI to quantify the burden of atherosclerosis. We're able to look for specific plaque features that are vulnerable. And now with the advent of FFR-CT, evaluate for lesion-specific ischemia. That's going to be my focus here today. So before we get into the CT-based FFR, let's kind of just review in general what is fractional flow reserve. So for those who don't know in the room, this is a measurement that is designed to evaluate the blood flow across a stenosis and whether or not it's hemodynamically significant. So is the stenosis going to impede blood flow to the myocardium that blood vessel provides? And so what we do is we measure the distal coronary pressure with the pressure wire, typically in the cath lab, and then we divide that by the proximal coronary pressure, and this has to be done under conditions of maximal hyperemia. Typically, what we've observed was that in the FAME-2 trial, as we decrease this number in the fractional flow reserve, this ratio, there's a corresponding increase in risk of major adverse cardiovascular events. And there's an inflection, kind of like an increase in the rate of MACE that we observe right around 0.8. And so we arbitrarily define 0.8 as this cutoff for a negative or a positive FFR. But keep in mind that it is a continuum, and there is a gray zone that I'll discuss in a little bit. Obviously, so an FFR value less than 0.8, much higher risk of MACE. Less than 0.8, we consider that negative, even though there may still be an increased risk of MACE. So now with CT, it's possible to estimate FFR. There are a number of different techniques, which we'll describe here momentarily, but what's really cool about CT-based FFR is that we can ascertain this data without any significant change to the CT protocol. So it's obviously non-invasive, and applying this strategy, as I'll discuss, there's huge benefits to both patients and health systems. For patients, we can avoid a lot of unnecessary casts, we improve health outcomes, and we can save health systems some money. Perhaps the most established strategy for determining CT-based FFR is using computational fluid dynamics. I'm not even going to pretend to fully understand the physics underpinning this strategy. Suffice it to say, we submit a CT data set to the vendor. They extract a 3D anatomic model from the data set, and then using a computational fluid dynamics, they produce this physiologic model, which we can leverage then to calculate FFR throughout the coronary tree and across all the major epicardial stenoses. So why is this important? Why are we so interested now in trying to understand physiologic information from an anatomic data set? A lot of the prior speakers have already touched on this. I think if we look at the totality of all the randomized control data that's available right now, one could reasonably assume that coronary revascularization should not be based on stenosis severity alone. All right, that does not lead to improved outcomes. And if we pluck out a couple of the major trials going back, to 2007, 2009, COURAGE and BARRY 2D, we see this. In the COURAGE trial, for example, they looked at over 2,000 individuals who had angiographically obstructive disease and were randomized to either PCI or medical therapy. And after several years, it was obvious that there were no significant change in heart outcomes, including death, MI, and stroke. Similar data observed in the Berry 2D trial, which looked specifically at diabetics. When they were randomized to either medical therapy or revascularization, no significant change in outcomes. In contrast, when we apply a physiology-guided revascularization approach, there is a significant change in outcomes. So this is data from the FAME2 trial, where patients with an initial FFR-guided PCI strategy were randomized. And you could see that there's a significant improvement with decline in urgent revascularizations as well as myocardial infarctions in the patients who underwent PCI compared to medical therapy alone. This trial also kind of showed, it highlighted that patients who have no physiologically significant stenosis, so negative FFRs, fared very well with medical therapy alone. So now we have this opportunity to provide a comprehensive evaluation of both coronary anatomy and function with one CT-based imaging session. We're leveraging, again, the sensitivity and negative predictive value of the CT angiography data set. But because of the relatively modest specificity that CTA offers, we weren't able to always accurately confidently call significant stenosis once we get into that kind of moderate to even severe range. So often patients angiography were found to have a moderate stenosis. Those patients would go on and get functional testing, either a stress test or sometimes even invasive cath. Obviously, with FFR CT, we can improve the specificity for these moderate lesions and offer the comprehensive assessment in one imaging session. So how do we interpret FFR CT? By convention, we typically measure the FFR CT distal to the stenosis in question. Lesions that have an FFR CT greater than 0.8 are considered to not be hemodynamically significant and can be managed medically. And lesions that have a low FFR CT, specifically less than or equal to 0.75, those are the lesions that we really worry about. They're thought to be hemodynamically significant, impair blood flow to the distal myocardium, where we really need to consider invasive cath and revascularization. Now we have this gray zone between 0.76 and 0.8, where we often have to sort of do some deeper digging and look at other features of the stenosis to adjudicate whether or not it kind of belongs in this medical management category or if invasive cath is really the appropriate course of action. So specifically, are there high-risk plaque features? Does it have the positive remodeling, spotted calcification, low attenuation plaque, features like that? Is the stenosis proximal versus a distal lesion, which would be lower risk? What is the plaque burden? Dr. Budoff mentioned earlier there's this incremental, increased risk of events with increased in overall atherosclerosis burden. And then we also have we can also assess the translesional FFR CT or the delta FFR CT. Jonathan Leipzig and his group did a study a few years back which looked at this, and if you look at the drop in FFR CT across a lesion, if that's greater than 0.13, that confers independent higher risk for that lesion. So we can upstage it, when we observe that if the FFR is within this gray zone. How does FFR-CT perform relative to some of the other imaging tests out there? If we look at the results from the Pacific study, which was mentioned earlier by Dr. Morris, it performs quite well. Obviously, this was a study, a very interesting study where patients underwent a battery of non-invasive tests followed by invasive cath with invasive FFR as a gold standard. And it looked at overall accuracy. FFR-CT fared the best with an AUC of 0.94 compared to even myocardial perfusion PET, which had an AUC of 0.87, and coronary CTA, which had an AUC of 0.83. So beyond even some of the clinical benefits, improvement in outcomes, reduction in MACE that we observe with FFR-CT, There's a number of other economic benefits with this strategy. We can avoid unnecessary downstream testing, we improve our cath lab efficiency, and we can save health systems a significant amount of money. So I'll dive into each of these briefly. Data from the platform trial back in 2016 by Pam Douglas showed that when we incorporate an FFR CT approach, about 83% of patients can safely avoid unnecessary cath. And that's profound. It's not data that you necessarily want to just take to your C-suite administrators at your hospital, because it may be met with some concerned faces. Obviously, a reduction in cath, raises some alarms. A lot of hospitals generate a lot of revenue from the cath lab. They want to keep that cath lab busy. But if you go on to explain to them that you're improving your cath lab efficiency, even though you're sparing patients unnecessary caths, you're improving your cath lab efficiency, it tends to put them at ease. So what do I mean by improved efficiency? Well, when you take a patient to the cath lab, if you incorporate the FFR approach, you're going to do a lot more appropriate revascularizations. So the number of revascularizations relative to ICA jumps way up. In the platform trial, it jumped from 32% to 72%. And so you end up actually revascularizing more patients when you incorporate an FFR CT approach. And this has been validated in a number of other trials. You also can save your health system a lot of money. In the platform trial, they observed a 26% net cost savings to the health system, and that's after even accounting for the cost of the FFR CT analysis. Again, because you're preventing a lot of unnecessary downstream testing, improving that cath lab efficiency. We mentioned earlier that FFR CT is now endorsed by the updated ACC AHA chest pain guidelines. So these were updated in 2021, multi-society guidelines, which give a real strong endorsement for coronary CTA and FFR CT. So Dr. Budoff mentioned earlier, coronary CTA was the only non-invasive study that received a level 1 recommendation with level of evidence A for both acute chest pain and stable chest pain. So the only study to receive that 1A endorsement. What about FFR CT? Well, it was given a 2A recommendation, which is still very respectable, specifically in patients who are found to have a coronary stenosis ranging between 40 and 90% on the CT angiogram. And they go on to say that this can be useful for the diagnosis of vessel-specific ischemia to guide decision-making regarding the use of invasive cath. So important to note that this applies to both patients with stable chest pain as well as acute chest pain with both suspected coronary disease, so no known coronary disease, as well as patients with established coronary disease. So the 2A recommendation for FFR applies in all 4 of those scenarios. So again, why are we evaluating, why specifically the 40 to 90%? Dr. Morris hit on this a little bit earlier. I'm going to dive into it a little bit more. If we look at some data from the advanced registry, it's important to note that the correlation between stenosis severity and FFR is not great, all right? So we can avoid a lot of false negatives and false positives when we incorporate this FFR approach. If we look at the advanced registry data and we look at stenoses, in that 30 to 50% range, which are, CAD-RADS 2, kind of mild stenosis by CT alone, 44% from this registry were hemodynamically significant and had a positive FFR. That's significant. About a quarter to a fifth of the lesions in the circumflex and the RCA also had positive FFRs within this mild range. And so lesions that appear mild angiographically, on CT can still be functionally significant. So we avoid false negatives by incorporating FFR. On the flip side, a lot of lesions in that severe range, 70 to 90%, can be hemodynamically insignificant and have negative FFRs. And again, if we look at data from ADVANCE, in the circumflex, 39% of these lesions actually were functionally insignificant. So lesions that, even though it's severe by stenosis on the CT angiogram, they can still be functionally insignificant. It's also worth mentioning that FFR-CT findings can now be used in lieu of invasive IFR or invasive FFR based on updated appropriate use criteria for revascularization for stable ischemic heart disease. So if a patient undergoes CT with FFR and there's a stenosis that is functionally significant, positive FFR, that is grounds for revascularization, all right? Now, obviously, a lot of interventionalists are still going to confirm this invasively in their lab, but that stenosis would be greenlit for revascularization based on the CT data alone. I also know that we briefly touched on the PRECISE trial earlier. I want to kind of highlight this again because I think the results are significant. This was a trial relatively recently that was really the first randomized trial to look at the clinical efficacy of these updated 2021 chest pain guidelines. And what they did was they randomized patients into one of two different pathways. We have the precision pathway, which was really a CT first pathway. The overwhelming majority of patients in the precision pathway underwent cardiac CT, and 40% of those patients also had an FFR CT performed. And then the other arm of the study was this traditional testing pathway where it was really kind of more of a stress test first pathway, okay? Only a minority, 1% of patients in traditional testing underwent cardiac CT with FFR. So these patients were followed for 1 year, and it was pretty obvious that there was a profound improvement in outcomes with the precision pathway. So 70% reduction in this composite endpoint, which is a little funky. It's combining hard outcomes with catheterization without obstructive coronary disease. So there is some bias there, but nevertheless a pretty profound separation in outcomes in these two groups. In addition, if we look at those patients in both arms who had suspected coronary disease, the number of invasive coronary angiograms was similar in both groups, so 18 in the traditional testing versus 14 in the precision pathway. But what I think is also very important is if we look at the total number of revascularizations, the total number of appropriate revascularizations was higher in that precision pathway arm, and the number of invasive angiograms with no obstructive disease was much less. So kind of reinforcing the efficiency of the CT, FFR CT pathway for improving appropriate revascularizations and eliminating a lot of the unnecessary invasive CAS. Digging a little bit deeper, if we look at, okay, so what's driving a lot of the improvement in outcomes? A lot of it is just an increase in preventive therapies and compliance for patients that underwent this precision CT first FFR pathway. So there was a 20% increase in use of lipid lowering agents and a 32% increase in the antiplatelet agents for patients in this arm of the trial, the precision pathway. All right, so what are some of the limitations of FFR? It's not perfect. Obviously, artifacts affect interpretability. Same applies to CT, right? If you have crappy data, you're gonna have a crappy angiogram, you're probably gonna have a non-diagnostic FFR data set. Long calcified plaques can also be a problem for some of the vendors in their 3D modeling. And then in patients with microvascular disease, some of the models of adenosine-mediated hyperemia can actually overestimate the degree of vasodilation. So that results in these FFR values that are actually below invasive FFR. So there's a potential for some false positives in the setting of microvascular disease. And there's really not much validation yet approved for coronary stents and bypass grafts at this time, although that will be changing in the near future. I've got a few cases just to highlight the added value of FFR. So case one, 44-year-old male with hypertension, hyperlipidemia, presented with atypical chest pain. This patient had a strong family history of coronary disease and had an elevated LP little a of about 120. We see the coronary angiogram here. There's a heavily calcified osteo left main lesion, but then in the proxial AD, there's a partially calcified plaque, about 50% stenosis. So kind of like right around like a CAD-REDS 2/3 lesion. That patient had their data sent to FFR for analysis, and the FFR CT distal to that stenosis was 0.77. So kind of like in that gray zone. But this was a proximal lesion. It was felt to be significant, and so a decision was made to take the patient to the cath lab. At cath, they confirmed the stenosis of 60%. Invasive FFR measurement was 0.74. So I think this case, very simple case, it kind of highlights that the value of FFR for sometimes adjudicating some of these intermediate stenoses and differentiating intermediate stenosis, in the setting of kind of suboptimal image quality. So sometimes when there's mild to moderate artifacts, sometimes FFR can be very helpful, leaning one direction or the other. Case 2, 32-year-old male with hypertension and hyperlipidemia presenting with acute chest pain. This patient came to the ER, had a heart score of 3. We see that the CTA, there was a possible severe stenosis of the prox RCA. It was read as greater than 70%, but there was some concern that maybe this was related to some banding artifact within the segment. So the study was sent to FFR for FFR analysis due to the possibility of this severe stenosis, and sure enough, just beyond that stenosis, there was a FFR of 0.74, considered hemodynamically significant. So patient again went to ICA, which confirmed a high-grade stenosis of the proximal RCA with an FFR of 0.72, and so the patient then underwent PCI and aggressive preventive therapy. All right, last case, 56-year-old female with hyperlipidemia, smoking history with stable chest pain, underwent coronary CTA, which showed some non-calcified plaque in the mid-LAD, and this was read as kind of a moderate to severe stenosis, somewhere in the 50 to 70% range. So we sent the data for FFR CT, and the FFR CT was 0.86. So I don't think the providers were convinced that that was accurate, so they decided to still take that patient to the cath lab. But the cath lab also confirmed that there was no significant stenosis, so an FFR is 0.84. So again, sometimes, in the setting of mild artifact, FFR can be very helpful in adjudicating whether or not a lesion is hemodynamically significant. So I think, in summary, the FFR CT is really kind of the preferred choice in patients presenting with both acute and stable chest pain. Why is CT a preferred first-line test? It's really the only Class 1 test with the Level A evidence in the updated guidelines for diagnosing coronary disease and guiding treatment decisions. It yields improved diagnostic efficiency. It's really the best test out there non-invasively to definitively rule out coronary artery disease. It has that high negative predictive value, which we discussed. And we do know with recent data there's a reduction in MI and cardiovascular death when we incorporate a CT-first approach to chest pain assessment. What about FFR CT? How does this add to further improve care? As I mentioned, it has a very high accuracy compared to other non-invasive tests. It leads to improved health outcomes. It reduces unnecessary catheterizations, improves that cath lab yield, and can save health systems money. And we know it also now satisfies the appropriate use for the cath lab registry. So we can actually make treatment decisions directly from the FFR CT data. Well, thank you all for your time, and I think we'll take questions later. Is that right? Yeah.